Extract 1, questions 1 to 12. You hear a doctor talking to a patient called Mr. Gwalither. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, doctor. Good morning. Good morning. Can you tell me about your problem? Doctor, I have had a skin lesion for the past 12 months. When I approached a local clinic, I was told that it is a skin tab. Do you have any pain? No, doctor. Any bleeding from the lesion or any trauma? No, doctor. I would like to evaluate and have a treatment for this. Okay, what's your age? 44, doctor. Do you drink or smoke? I'm a regular smoker, but drink very rarely. Where do you work? Actually, I do dynamite work, and in fact, putting in the dynamite in large holes for breaking ground for laying pipelines. I do frequent traveling for this work. Does anyone in your family have prostate cancer, kidney cancer, or any other illness? Nothing of such kind, doctor. Do you get fever? No, doctor. Are you positive for HIV, or do you have any STDs? No, doctor. Have you had any surgery in the past? Yes, doctor. I had back surgery with fusion of L5S1. What medications are you taking? I take Percocet occasionally for back discomfort. Are you allergic to any medicine? No, doctor. Well, your physical examination shows your blood pressure is 144/66, weight 177 pounds, your heartbeat rates and rhythm are regular. You have pedunculated lesion on the dorsum on your penis that is apparent. There is also another brown lesion mildly raised. Your testicles are bilateral and descended without masses. I think you have developed genital warts called molluscum contagiosum caused by human papillomavirus. The etiology is unknown, but it's most likely sexually transmitted. You have developed a viral infection that could have had a long incubation period. I suggest that from now on you have protected sexual intercourse to control the further transmission of the disease. Apply Condylox cream on the lesion for a period of 1 month. I suggest a CO2 laser therapy for the genital warts, which is just an outpatient procedure. However, there is a 20% chance of recurrence despite enucleating these lesions. Okay, doctor. I would like to go for a CO2 laser therapy.
Boy, age 10. Now take notes on the case history and current symptoms.
So your GP suggested you bring Tony in?
Yes, we've had a very bad night. He's had hardly any sleep, wheezing, out of breath and coughing. I was really worried, so I rang up Dr. Cooper.
Does he use a blue inhaler?
Yes, he's had one for years.
But it didn't help?
Not this time.
Is his asthma normally under control?
Well, he's had it since he was 4. I was worried about him going to school at the start, but he seems to manage most of the time.
Have you any animals at home?
No, he wanted a pet, so we got him a cat, but it made his condition worse, so he had to give it away.
Have you noticed if he's allergic to anything else?
Well, we try to keep dust down in the house.
Who did you see about Tony's asthma in the first place?
We were sent to St Mary's and he had lots of tests to see what he was allergic to.
And what were the results?
Oh, he was allergic to lots of things.
So he was put on Intal, was he?
Yes, he took that for years regularly, but a year ago his asthma got worse and our GP changed inhaler.
Does he now use a brown inhaler?
Yes, he uses it regularly.
Is there anyone else in the family with hay fever, eczema or asthma?
Oh yes, my mother had asthma all her life. I had eczema as a child. On my husband's side, several people have hay fever.
Has Tony had any illness apart from asthma?
No, fortunately not. That's enough.
Has he ever had to come into hospital before with a similar attack to today's?
Yes, they put him on steroid tablets. Another time, he was rushed into intensive care and put on a machine to help him breathe.
Has he a nebulizing machine at home?
Yes, and a peak flow meter. The asthma nurse showed us how to use it.
What is Tony's usual peak flow rate?
300,
And what was it today?
100. He's been very restless all night and breathless. He took more and more puffs, but he's just the same.
Does anything special bring on one of these attacks?
It seems to be when he gets a cold.
That's very common. Well, Tony, I'm going to bring you into hospital to get you sorted out, all right?
Thank you, Doctor. That's a relief.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear an optometrist talking to a patient who's trying contact lenses for the first time. Now read the question.
Now, you've had the lenses in for a few minutes. How are they feeling?
Not bad. I thought I'd feel them actually touching my eyes, that they'd be sore or prickly, but I can't feel much at all. My eyes do feel a bit watery, though.
It's okay. You've just used too much solution. Now, in a few minutes, I'll get you to try taking them out and inserting them again by yourself.
I had no trouble taking them out earlier, but I'm not confident about putting them in. I worry I'll press too hard.
That's unlikely to happen.
Things look rather distorted, though. I mean, I can't make out the letters on that chart.
Any of them?
Those lower down.
Let's give things another minute to settle down.
Question 26. You hear a nurse asking a colleague for help with a patient. Now read the question.
Kathy, could you help me with the patient in bed 103? The woman who had surgery 2 days ago.
Oh, yes, she's due for discharge today, isn't she? Does her pain relief need topping up again? I thought she wasn't very comfortable this morning.
Oh, she's on a reasonably low dose, but she's coping. She needs her chest drains removing, though, and she's got herself into a bit of a state.
Ah, well, that's a two-person job anyway, so I'll come with you. Has the consultant seen her? I know there was some concern yesterday about her condition and the level of the fluids draining into the bags.
Oh, he's cleared her for removal of them today, but I think some reassurance might be needed first.
Right. I might just check her analgesia and give her more before we go ahead.
Okay.
Question 27. You hear a senior nurse talking about a new initiative that has been introduced on her ward. Now read the question.
One of our key priorities is improving communications between staff, patients and patients' families. We recently introduced a scheme called Dear Doctor, which involves giving each patient a card where they can make a note of any questions or concerns that they themselves have. They can also talk to their families during visiting time, or even on the phone, and see if there's anything else they'd like to add. The cards are then collected and given to the doctor before the ward round. We're really pleased with the response. Patients used to say that they only thought of the things they felt they needed to discuss when it was too late, so the cards give them a better chance to bring up whatever's on their minds. In fact, it's been so successful that we're going to roll it out on all wards in the hospital.
Question 28. You hear two radiologists talking about the type of scan to be given to a patient. Now read the question.
I've just had a phone call from emergency. They have an 11-year-old boy with right lower quadrant abdominal pain. They're concerned about appendicitis, and they'd like to order an abdominal CT for him.
Do you think that's a good idea?
I was thinking maybe we should recommend an abdominal ultrasound, because then we can spare him the radiation.
Is there any concern in this case around using ultrasound instead of CT? Accuracy, for example.
The sensitivity is slightly less than the CT, but the specificity is almost the same, so I think we can rely on the results.
Okay. It means we can avoid the child being subject to contrast exposure as well. But what would we do if the ultrasound doesn't answer the question?
If we can't visualise the complete appendix, then we can recommend an abdominal CT.
Okay, we have a plan. Call them back and let them know.
Question 29. You hear part of a surgical team's briefing. Now read the question.
Okay, next is Mr. Malloy's repeat laparotomy. Any anaesthesia issues?
We don't expect any particular problems. He's relatively fit and well, except for his epilepsy, which is under good control. His BMI is 35, but...
Will we need the obesity bed?
It shouldn't be an issue.
And what about the epilepsy post-operative management?
He's taking his oral medications, and we can use an IV if necessary.
I know he was in a lot of discomfort after his last surgery, and this time he's going to need a larger midline incision. It may be worth thinking about an epidural. He's certainly at the extremely low edge in terms of pain threshold.
Question 30. You hear a senior research associate talking about a proposal to introduce interprofessional primary healthcare teams. Now read the question.
We're looking at opportunities to improve the effectiveness of health and healthcare systems here in Canada. One of the interventions we're looking at is interprofessional primary care teams, groups of professionals working together collaboratively to provide services including healthcare, social services, and advice to patients within the primary care setting. There's evidence that teams like these can improve chronic disease outcomes, including diabetes, hypertension, and heart disease, as well as mental health problems. There's also evidence that improvements can be made in terms of both access to and coordination of care. Now, the extent to which these teams could affect the costs of healthcare in such areas isn't quite clear within the evidence, but the work we're doing aims to address such issues while looking at the challenges of implementation and evaluation.
Part C, questions 31 to 42. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with Dr. Christine Erickson, who's talking about her research supporting non-fasting lipid blood tests for cholesterol. You now have 90 seconds to read questions 31 to 36. Hello and welcome to Health Research Roundup. For decades, people have been asked to fast before they have blood tests to check cholesterol levels. However, a new research report from an international group of experts suggests that this is not necessary. To discuss this research, my guest today is Christine Erickson from Copenhagen University Hospital, who was a lead author of the study. Christine, welcome.
Thank you very much.
So why did we ever ask people to fast for blood lipids, for your blood fats?
Well, if you ask me, I don't really know, except for that's what we've been doing for so many years. I really tried to read the literature and find some very scientific evidence supporting that it is superior to just taking a random non-fasting blood sample as we do now. And I had problems finding the evidence. There's a lot of arguments people put forward for why you should use fasting versus non-fasting, but really solid evidence that is better, I can't find it.
So was this a tradition rather than science?
I think so, yes. I mean, you can ask me why did it start? I think that some of the early studies, the original publications way back, said that they used fasting samples and therefore everybody thought you had to do that without really thinking why. But those early researchers may have had good reason to do it that way, but there's nothing I've seen that said it had to be done that way. And there's all this evidence now from Canada and the US, 2 excellent studies, one in children and one in adults. And then we have a lot of studies from Copenhagen, and they all show that when you just look at people that eat and drink whatever they usually do, and you take a lipid panel, cholesterol, triglycerides, a very common fat in the blood, then they don't really change very much in response to when you have been eating.
So there is a difference?
Yeah, the difference is in millimoles per litre. So it goes up by about 0.3 millimoles per litre. However, in clinical practice, when you look at triglycerides, you're interested in whether it increases 1 or 2 millimoles, not 0.3 millimoles. So that's what's clinically relevant.
And even with a bad form of cholesterol, that's not going to make the difference between whether or not they put you on medication?
Yeah, that's right. We provide data in this report where we did direct measurement and after fasting, and in about 6,000 people, and the correlation between the 2 methods was, I can't see the difference. It looks exactly the same.
So you moved over in Denmark to this official recommendation about 7 years ago. So what's happened since then? Have there been any issues because of undiagnosed cholesterol levels?
No, everybody was happy right away. Even the laboratories that didn't change right away, they were pushed by patients because there were reports in the media telling them that at Copenhagen University Hospital we're doing non-fasting, so everyone wanted to do it. And I can say today, patients, clinicians, laboratories, everyone's happy. Everyone likes it because it's so much simpler.
And patients like it because they can go when it suits them to the pathologist, so they're more likely to turn up for their blood tests?
Yes, of course. I don't have fantastic good numbers for you, but certainly you hear from so many colleagues that people don't go to have their lipid test because it's so complicated to fast. And then they have to go to work, to have an important meeting, and they can't do this in the morning. But now, doing a random non-fasting, you can come whenever it suits you.
And very briefly, is there any circumstance where you should have a fasting blood fat level done?
Well, this recommendation, it's 21 world experts, many from Europe, the US, and one from Australia also. And of course, when you have so many experts, there's always someone that thinks there's certain situations. We list a few where you can do. For example, for patients with diabetes, the fasting requirements might be an important safety issue because of problems with hypertension.
Now turn over and look at extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42. You hear a specialist in medical ethics called Anna Capston giving a presentation on the issue of burnout in the medical profession.
Hi, I'm Anna Capston from the Division of Medical Ethics at University College. Today I want to discuss the quite urgent topic of burnout among medical professionals as it's becoming. It's kind of an epidemic, but I really think that we're not talking about this enough. That's why we're here today, to get a bit of information out there and start a conversation. So, what is it? Well, burnout is a psychological and behavioral syndrome. Emotional exhaustion is one quite common hallmark of burnout. It's been defined as long-term, unresolvable job stress, a sense of being overwhelmed and depersonalized and lacking a sense of personal accomplishment. A recent study from the Mayo Clinic showed that in 2011, 45.5% of doctors reported that they felt burned out, and that number has now risen to 54.4% in 2014. More than half of all doctors in this country are saying, "I really feel that some aspect of my work as a doctor is making me feel burned out." This is really trouble. It's trouble because a doctor who feels this way can commit more errors. They suffer from compassion fatigue, or just not being able to empathize with others because they have their own emotional issues. They may retire early, therefore reducing the workforce. They may have problems managing their own lives. 400 doctors committed suicide last year, which is double the rate of the population average. There's trouble for patients in having a workforce that's burned out. There's trouble for doctors in terms of their own health and well-being. We don't talk about it much. We like to think that doctors can handle everything, but it's clearly not true. It's a problem, and there ought to be some solutions. One type of fix is to make sure that hospitals and other healthcare environments try to create better conditions for a happy workforce and for happier doctors. This might include yoga, mindfulness training, having more therapists to talk to, encouraging people to come forward when they feel this way, peer groups, and better mentoring. There are a lot of tactics that we could pursue and try to engage in. I'm not sure what's best, and maybe one size does not fit all, but it's time to really build a safety net so that we can keep our workforce functioning and we keep physicians at their careers and doing a good job, not making mistakes, not being indifferent to patients, and not harming themselves. This really is a problem, and we've got to attend to it in the workplace. It's just as important as any other aspect of workforce safety. When we institute new software, or when we have new bureaucratic regulations, I think somebody ought to ask, what does this do to the workforce? If one more doctor complains to me about Epic and other types of electronic record keeping and billing forms, it'll be one doctor too many. It takes a lot of energy, makes a lot of people unhappy. A lot of the software and computer assistance that's out there doesn't seem to help the doctor. It makes more work or makes them feel frustrated. It also seems to me that if you look at what's going on with respect to regulations and administrative or bureaucratic requirements, nobody is saying, hey, is this user-friendly? What's the burden that it's putting on the doctor? It's just done to save money or allow people to collect bills more reliably, but it's not asking what it's taking out of our workforce. I believe that morally, we've got to make sure that a highly trained workforce that takes a very long time to get the ability to practice medicine is a resource that we preserve and really take seriously. I don't think we're doing that as part of employee or workplace safety. I think it's crucial, but it's being ignored. We also have to view it as part of patient safety. And I think we should start spending some resources to figure out how we can make the physician workplace more user-friendly. How can we make it a happier place to be? What can we do to institute regulations, guidelines, software, and bureaucracy to try it out on the workforce for a while to make sure that they're satisfied and that it's not making their lives more miserable?